It's wonderful to see so many colleagues and friends gathered here in Columbus today for our Quality Summit, this being our 12th annual. In this summit, we're focusing on high reliability organizations. We might all agree that achieving high reliability in healthcare requires hospitals to have exceptional leadership, perpetuate a true culture of safety, and often engage in robust process improvements that just don't happen rapidly. Today's healthcare leaders are preoccupied with failure, have a reluctance to simplify processes, have a sensitivity to operations, defer to expertise, and are committed to resilience. These are the principles that healthcare leaders live in their daily practice, and they are the principles of high reliability organizations. And today, we are hosting 3 panels of leaders. Our first panel will address the very principles that we mentioned and how they add value to the hospital. Our second panel today will focus upon high reliability rounding in hospitals and health systems. And our final panel will deal with equity in care, a major component of healthcare today. You will hear these leaders talk about a variety of quality and patient safety initiatives throughout the day. But on behalf of the leadership of the Ohio Hospital Association, I'm very pleased to host a very diverse audience this year, made up of our OHA members, participants in the OHA Hospital Improvement Innovation Network, fellows in the American College of Healthcare Executives, students pursuing graduate degrees in healthcare leadership, quality leaders, and hospital C-suite executives. To all of you, I say welcome. And also joining us via live streaming are members of the Minnesota Hospital Association, their Hospital Innovation Network, with whom we've integrated our efforts to accomplish many designated improvements surrounding antimicrobial stewardship and iatrogenic delirium, to be very specific. Also joining us are our colleagues from the New Jersey Hospital Association and the Hospital and Health System Association of Pennsylvania. So again, for those who are joining via live streaming, we welcome you. Before we begin today's presentations, there are a few details I'd like to review with you. So first, if you wish to claim continuing education credit for your participation today, you will need to please complete an electronic evaluation. Evaluations are electronically being submitted, and a certificate then will be issued to you via email. So please make sure that you are indicating your name as you wish to have it on the certificate, as well as a current email address that you can receive that at. This program is approved by the American College of Healthcare Executives for ACHE face-to-face education credit. So regarding that continuing education credit, it is required that you sign in for each of the sessions. And so on your place right now, there is a blue sign-in sheet. Each session, each panel will have a different color sheet. We ask everyone to sign in, whether you are a fellow, whether you are a member of ACHE or not, so that we can record your attendance. For those of you that are fellows in the college, this document then will be sent to the college, and then your credits will be available in your mychache.org account in your profile. So it's very important that you do that, and I would just remind you to do that with each session. That will be posted within 4 to 6 weeks by ACHE. Also, just so you know, we will have session moderators, as we typically do, circulating the room, and you'll see question cards on each of your tables. And we encourage you to list any questions that you have while the presenters are presenting. If you have a question that comes to mind, please feel free to jot it down. At the top of the card, it asks you to just list which of the panelists you're addressing the question to. The moderators will circulate the room and collect these. They'll bring them up to the panelists so that they can answer your questions. And we'll do that in the aggregate at the end of the presentation. Third, we are very, very privileged today to have 70 evidence-based poster abstracts addressing a wide variety of quality and patient safety topics. We encourage you to spend the allotted time on your agenda and visit each of these poster presenters as time permits. I can tell you from having reviewed the abstracts, which are located at each of your places in the spiral-bound book, these are yours to take back, that these are abstracts that involve a great deal of work and a lot of improvement. And we're all about disseminating best practices and sharing lessons learned. So to all of the evidence-based poster presenters, we thank you very much for presenting. Continuing education credit is available for the time that you do spend with the poster presenters. So all you'll need to do is complete the evaluation for the poster presentation, and you will also receive credit for that as well. I just want to let you know that none of our panelists for any of our sessions today have indicated any perceived or actual conflicts of interest to disclose. And now I would like to welcome Dr. Kevin Webb. Kevin is the president of Acute and Ambulatory Care at ProMedica in Toledo, Ohio, and Dr. Webb will moderate our first panel. Kevin, pleasure.
Thanks, Jim. Our first panel today will focus upon the principles of high reliability organizations and the value that they add to both the patient and healthcare organization alike. This particular topic is near and dear to me. I have 3 members of my family that died as a result of medical errors in hospitals. My grandmother died due to a medication error. My father died as a result of complications from a surgery that, as it turned out, he didn't need. And my mother-in-law died most recently of an outpatient procedure. Complications from an outpatient procedure happened to be a vertebroplasty, and the cement material got into her bloodstream. She developed pulmonary emboli and died 3 days later from an outpatient procedure. So anything that is going to reduce human error or improve our predictions and our predictive capabilities, I'm all for. To begin, we're joined by Dr. Ellen Amalfitano, who will present highlights of the principles of high reliability organizations. Dr. Ellen Rice Amalfitano is the Vice President of Safety and Reliability at Bon Secours Mercy Health System in Cincinnati. As a health system leader, Ellen has experience in healthcare leadership and operations, and now she leads her health system safety and reliability team. She's a certified professional in healthcare quality and is a 6 Sigma Green Belt. Ellen holds an associate degree in nursing from Santa Monica College, a Bachelor of Social Work degree from Temple University, and a Master of Public Health from Drexel, and a doctorate in healthcare administration from Walden University. Please join me in welcoming Ellen.
Good morning. It is my pleasure to be here this morning with this group of healthcare leaders from across Ohio to talk to you about one of my favorite subjects, which is reliability. And over the course of the next 20 minutes, we'll talk about reliability, what it is, why it's important, how to get more of it, and we'll talk about how Bon Secours Mercy Health is on a journey to really operationalize high reliability within our new integrated health system. But before we start, I want to throw out there the idea that reliability is a verb, a noun, an adjective, an adverb, which makes it very difficult at times to have a common understanding when we say the word reliability. So what I'd like us to walk away from this room with today is some common verbiage, understanding, and concepts of reliability. So we as health leaders, when we go back to our organizations and our health systems, can clearly communicate reliability to those that we are leading. So with that said and done, let's talk about Bon Secours Mercy Health. Many of you in the room may be aware that Mercy Health merged this past year with Bon Secours, a health system primarily along the East Coast. And we are now one of the largest Catholic health systems in the nation, with over 1,000 sites of care in 7 different states. And we are privileged to lead over 57,000 employees. And it's very important to think about those 57,000 employees when we talk about reliability, because there's where we have a great deal of variation in those 57,000 different human factors that are in our facilities. Bon Secours Mercy Health is a faith-based organization, and we are both defined by and inspired by our mission statement, which is Bon Secours Mercy Health extends the compassionate ministry of Jesus by improving the health and well-being of our communities and brings good help to those in need, especially people who are poor, dying, and underserved. In order to operationalize our mission statement, we have core values, and these core values inspire us and drive the care that we provide, and unite us in our approach to care, and their human dignity, integrity, compassion, stewardship, and service. These are the core values that define who we are as a health system and how we deliver our care. So that said and done, Bon Secours Mercy Health is big. And we have all the bells and whistles for safety, and you'll recognize many of these. You probably have them in your organizations. We have nurse-driven protocols. We have sepsis screening tools, best practice alerts, hard stops, tall man lettering, more. And yet still, we have harm. Harm happens. So how does harm happen if we have all of these safety tools? Well, let's stop for a minute and also think about harm. Harm is another one of those tricky words, which can be a noun, a verb, an adjective, and an adverb. And sometimes when we talk about harm in a room full of people, everybody debates what is harm and did we cause it? Causation, correlation. These things distract us when we start to talk about harm. But I'm going to offer you a very simple definition of harm. Harm is anything unexpected that happens. Harm is an unexpected outcome. And how does that happen when we have all the safety tools? Well, we have three key variables in our care: our people, our process, and our technology. And on a good day, they align perfectly to deliver the outcome that we have designed them to give. However, on most days, there are variations in those people, process, and technologies. There's gaps and there's lapses. And those gaps and those lapses are what leads to the variation that results in the unexpected outcome, that harm, the harm that we are trying to prevent, the harm that Dr. Webb described that he's experienced personally and many of us have. So let's take a step back then at our human factors that are involved. We're going to talk about the case of the lamb cake. This is a classic example of technology, process, and people that resulted in an unexpected outcome. The unexpected outcome that we are talking about is the picture on the right-hand side of your screen, example number 1. What happened to result in that unexpected outcome? We had a piece of technology, which was a lamb cake mold, not a highly complex piece of technology, but that's our technology in this particular example. And in that piece of technology, there was a hole, and you can see by the arrow that hole. That was an intentional hole, came out of the package with that hole. We had a process, and the process was the baking of the lamb cake. And then we had a human factor. And the human factor was challenged by some typical human factors that we see in our common RCAs. The number one of these was Occam's razor. And Occam's razor is the theory that any explanation for a phenomena should have as few assumptions as possible built into it. So the logical explanation has no assumptions. Another way of operationalizing Occam's razor is, as my husband likes to say, if you hear hooves outside your window, it is probably not a zebra. So Occam's razor tells us that we should settle on the most simple explanation for any phenomena. In this case, there's a hole in the cake mold for a reason. Our human factor in this particular story decided to create a classic workaround. Not identifying what the hole was for and failing to actually do some research on what the hole might be for, our human factor took that simple piece of wax paper and put it over the hole and proceeded to try and bake the cake. There were some other factors involved in this disaster, and they included a failure to engage in a questioning attitude. So actually asking, why is there a hole? No, instead we just created a workaround. There was a failure to gauge in a reluctance to simplify. We're just going to cover up the hole. And then our individual was tired, they were pressed for time, and they had competing priorities. If you take those 5 points and you think about the harm that has resulted in your institutions, almost all of them will apply to any scenario that you're evaluating. The bottom right-hand side of the screen is what the lamb cake was supposed to look like. So unexpected outcomes are the results of gaps and lapses. And ultimately, the best laid plans that we have are threatened by the real world. They're threatened by those opportunities for variation. And we often talk in performance improvement and quality about making the right thing the easiest thing to do. And you'll see gaps and lapses that I've spelled out on the screen are examples, again, that many of us can relate to and really come from our best efforts to eliminate the opportunity to make mistakes, but they still happen because life happens and there are variations in life. So we can have a policy that says we don't take a verbal order, but in an emergent situation, patient care takes precedence over that particular edict. We have a smart pump, but if a drug is not in a smart pump for a variety of reasons, then that's a piece of technology that has failed us. So examples of these gaps and lapses that occur and lead to unexpected outcomes that are tangible and that you can relate to and that the people that you're leading can relate to are listed out here, and I'm sure you have many others of your own. So ultimately though, when we're talking about reliability, what we're talking about is reducing the variation and leading to our consistent outcomes. So another good example for where reliability comes into play has to do with the Subaru Forester. I don't know what you drive, and if you're familiar with the Subaru series, but the 2018 was really chock full with all kinds of wonderful safety tools. Blind spot cameras, backup cameras, steering correction, speed corrections, all kinds of fabulous things. But the one thing that the Subaru Forester could not eliminate was the human factor involved in the driving of the Forester. All right, so we know we can't eliminate the 57,000 employees at Bon Secours Mercy Health, nor do we want to. But we want to create a scenario in which we can assist them to drive towards the consistent outcomes and prevent harm. So in this particular story with the Subaru Forester, given that we cannot eliminate the driver, we can look at the situation and identify what are our potential areas of harm? And they're listed out in terms of mobile distractions, child and dog distractions, eating and drinking distractions, a lot of distractions, time constraints, and working from the road. So by identifying where our potential gaps and lapses are, we can build in people, process, and technology to prevent those from happening. And this is really how we begin to chip away at the opportunities for variation that lead to our unexpected outcomes or our harm. So ultimately then, high reliability comes down to achieving our expected outcomes. And that's the most simplest way I can think of for us to operationalize these concepts for those that we lead, is high reliability is achieving our expected outcome. That's pretty easy. I'm going to stop for a minute there because it occurred to me last night while reviewing the slides on the plane that actually high reliability is a bit of both a redundancy and an oxymoron. And I don't think I'm going to use the term high reliability anymore because reliability is reliability. It's not really high or low. It either is or it isn't. It's like we always do this. We can't always do it, but. If there's a but there, we haven't always done it. So if we're not highly reliable, we're not reliable. So I think I'm going to eliminate that high reliability term and just focus on reliability moving forward. But essentially, then reliability is the elimination of all known threats. So in the Subaru example, we can identify potential known threats and build our people and processes to eliminate those potential known threats. Now the challenge is the threats we don't know about, and that's our continual reassessment for new threats. And that's really our culture of safety. That's how we set our sensitivity factor to where are the potential for harm that we can eliminate before we get to the point where we're actually experiencing harm. So when we merged, Bon Secours Mercy Health took advantage of the opportunity of disruption. And we see in today's conference, we have disruption everywhere. And disruption is both a good thing and a bad thing. Wanted disruption, intentional and planned disruption can be very productive. Unwanted disruption can lead us to variation in outcomes. So we have to be careful when we think about disruption as a good thing or a bad thing. But in this case, our integration and our design of our preferred future state of our health system was a wanted disruption. And so we took some time, we stepped back and we thought about what's the missing component in our quality and safety program. And that really was becoming deeply embedded in high reliability or reliability. And AHRQ defines high reliability as an ongoing process or organizational frame of mind, not a specific structure, and not a specific overlay on top of what we're doing, but an infusion of the concepts within the work that we do and all of the work that we do. And we learned about these 5 components, or we just heard about them in Jim's opening, with this idea that reliability is based on our commitment to resilience. So you'll notice in the cake example that the bottom picture was the desired outcome. Well, that's because the human factor went to Pinterest and Google and learned the appropriate process for using the cake mold and then made the cake the right way when the human factor had more time and the appropriate education to use the tool and the technology. That's a commitment to resilience. That's a bounce back and saying, we can do this better. We can bake a better cake. A sensitivity to operations. So really understanding. And the Subaru's example, a good example of this, understanding where are our potential areas for accident, for harm, for variation, and filling those gaps. And building in that is that deference to expertise, going to the front line and understanding and not determining from back here or from research what those opportunities are, but going out and seeing how the work is done and getting deeply embedded in ferreting out those opportunities for improvement. That reluctance to simplify, not taking the easy answer, but digging a little deeper, asking those 5 whys to find out what really is driving the potential for variation. And then the preoccupation with failure. And although this sounds a bit dismal, like I'm the person who walks around and I'm preoccupied with failure, nobody's going to want to eat lunch with me if I'm that person, but really putting the positive spin on it. The preoccupation with failure because we can do this better. And that ties in with all of the other components within that wheel. We can do this better. We will do it better. Relentlessly and tenaciously seeking those opportunities to improve and engaging in the science of improvement. So then, once we've decided that we want to infuse all the work that we do with reliability principles, we acknowledged at Bon Secours Mercy Health, after taking a deep inward look, that there is a quality and safety maturity paradigm. And there's really 3 levels. There's a maintenance level, and that's the reviewing, the reporting, the required activities we do around safety on a daily basis. And then there's the improving component, and that's a slightly a level up. So we're not reviewing, but now we're doing. And we're doing with the science of performance improvement and with an eye towards reliability and reducing variation. And that enables us to move towards a fully mature paradigm of reliability, which is transformative. So it's really becoming proactive. But the problem is we spend a great deal of time in healthcare in the maintenance function because we're trying to catch up to the harm that we've already experienced. And any one of you who is responsible for responding to a safety or harm event knows the amount of time, resources, tears it takes to address, to redress, to repair, and then to restructure in response to a safety event. Think about those resources, both human time and financial. And if we could take that from the front end, or the back end, I suppose, and put it on the front end in terms of proactivity and harm reduction, how much more productive we can be. And that's really the goal. When we talk about getting from harm happen to harm won't happen, is getting a leg up on our safety events so we can get to the point where we can use our resources to prevent harm versus respond to harm. So how do we do that? That's a lofty goal. That's really great, Ellen, but how are you going to do that? Well, this is how Bon Secours Mercy Health has laid out the proposal for getting from harm happen to harm won't happen. And recognizing that there are certain activities, the foundational ones, the critical quality, the need to have to do before we can really fully move on to a transitional phase. And these are some of the activities that are involved in that foundational level of high reliability. And those are our safety huddles. And here's where you hear the safety language and that culture of safety. And our safety huddles are the embodiment of our commitment to ongoing process improvement and to ongoing identification of where those potential areas for harm or variation are, and then addressing them. So the safety huddle, our safety check-ins, our leadership rounding, these are 3 key tools that enable us to have that bird's eye view into where are those potential areas for harm. So constantly scanning the horizon for potential variation. And then our event reporting, event analysis, and our stand-down process are the key tools around when something has happened, how do we react? How do we evaluate, with a system our size in particular, the opportunity that more harm may be occurring right now as we speak? Because if it happens one place, it can happen another place. You know, we have never events. If we have a never event, it's not a never event. And so it could happen somewhere else simultaneously. And so as a system, as a health system, and even within the Ohio Hospital Association as a collaborative format, we have the opportunity to share our points of identification of harm and opportunity for variation to spread and share and prevent a simultaneous event from happening at a sister hospital. So then we recognize too, within the Bon Score Mercy safety reliability construct, that there's a transitional phase, and that transitional phase is working in partnership with our foundational phase. This is a recognition of the science behind performance improvement. And any of you who has been engaged in action planning, where you have identified education as your key action, will know that that is not the strongest action out there. And yet, how many times do we have an action plan for a root cause event where education is where we are hanging our hat? So we bring our performance improvement engineers into here to look at things from a slightly different aspect and to help us identify what's an actionable item, what's a non-actionable item, how will we measure the change that we desire to have, how will we course correct if necessary, and how will we sustain and spread. Most people don't have the time or the energy or the background to really zero in at that level, and we know this from our action plans that we've seen in the past. But including our performance engineers in driving our action plans and our RCAs and our change management, our project management, and our process improvement enables us to create harm reaction prevention opportunities that stick and that are sustainable and spreadable. Those are key words that we use: sustainability and spreadability across our system. And that enables us to move then to a proactive space where our preoccupation with failure and our reluctance to simplify get operationalized through our lessons learned, our near-miss reporting, our global trigger reviews, our predictive analytics, and we'll get into a little bit more on that in a bit, our failure mode and effects analysis, and our standardized workflows. So this is really the roadmap to get from harm happened to harm won't happen in a very intentional and methodical fashion. One could say it's a reliable fashion. So drilling into then these concepts, how do we make them tangible? Well, we've defined our scope of services for safety and reliability. And once again, you'll see you'll hear and you'll see the language that I presented on the previous slide around the culture of safety, our science of process improvement, and our approach to high reliability. And our culture of safety, again, some really specific safety behaviors measured by our increase in near-miss event reporting. So we all know ultimately we want to see those harm events decrease, but our near-miss event reporting is an indication of our buy-in, of our 57,000 employees feeling empowered to participate as full safety partners, as being the people out there that are saying, you know what? I just created a workaround and that's not good. Or, ooh, there's a process in place that's not working for us. Hey, can somebody help fix this before it causes harm? And so our near-miss event reporting is really an indication of the empowerment of those 57,000 people upon who we rely for outcomes every day in their engagement in safety, and we need them. And as leaders, this is why it's so important that we are able to verbalize our goals around reliability and harm reduction, is because if we don't understand those and we can't make the complex simple, how can we expect our employees to fully engage? And so coming up with examples that are tangible and personal that you can share help engage those employees. Process improvement, again, the science of process improvement and recognizing this as a discipline into and of itself. And really the outcomes then for our process improvement folks, and I think my CFO colleague might appreciate this, is our return on investment for our completed projects. You know, this is how we continue to grow and build, is by demonstrating the value of our process improvement. And if we can't demonstrate the value both in our outcomes as well as in our return on investment, then have we really done any improvement, or have we just engaged in process? And then high reliability. And I've not talked so much about this, but I will moving forward. But this is really the opportunity to identify and implement those harm reduction strategies using the science of reliability. And we have a great project I'm going to be very enthusiastic about sharing with you in just a minute that really demonstrates how we're seeping some process technology with our high reliability tactics. But our high reliability work is really responsible for ensuring that any action plans, any collaboratives, any performance improvement groups are not walking out of the room with a plan for education, but rather for a plan to seep our processes and our technology in the guardrails and the reliability tactics that will enable our people to achieve our desired outcomes. We're essentially setting ourselves up for success. So let's talk about sepsis. And I think everybody in the room knows about sepsis. And everybody in the room has probably spent a great deal of time in the past 5 to 6 years engaging in identification and rapid treatment of sepsis. If you don't know what a 3 and 6 hour bundle is, well, then we probably need to sit down and talk. But we've talked a lot about 3 and 6 hour bundles for the last 6 years. Bon Secours Mercy Health cares for over 22,000 severe sepsis and septic shock patients a year. That's a lot of patients, and that's just our severe sepsis and our septic shock patients. You'll see in the yellow box on our screen that we have variations in care. In comparison to top opportunity hospitals, we have excess days. We have some unexpected deaths. We have complications. All of the data in the yellow box are indicative of variations. We have those excess complications, excess days, because we have unexpected outcomes. Something happened. So what happened? Well, think about this for a minute. We've spent the last 6 years focusing in on the first 3 and 6 hours of our sepsis care. How long do sepsis patients stay in our hospitals? Sepsis patients stay in our hospitals anywhere from 4 to 7 days on the average. What's happening after the first 6 hours? Do we have standardized processes beyond the first 6 hours? I'm going to reiterate, we have spent a lot of time in the 3 and 6 hour space. But what happens to our patients after the first 6 hours? Well, we have fluid management concerns. We have IV to PO conversions. We have nutrition. We have mobility. We have decompensation. We have the need for follow-up appointments at discharge. We have home care referrals that need to be made. We have palliative referrals that need to be made. We follow up on blood cultures. We have myriad opportunities beyond 6 hours to standardize the care that we provide and minimize the variation in care. Remember, it's those variation that lead to our unexpected outcomes. So we have spent quite a bit of time at Bon Secours Mercy Health over the last few months analyzing our data and beginning to understand where these opportunities lie after the first 6 hours. And we have developed it's a short-term test of change that's designed to minimize our care variation after 6 hours. And before I launch into that, I just need to tell you, when I brought together the group of clinicians to talk about care beyond 6 hours, they kept wanting to lapse back into 3 and 6 hour bundles. And finally, I said to them, on these calls, you are not allowed to talk about 3 and 6 hours. There is no more talk about that. I said, that is a very comfortable space for everybody. I am taking you into a space that is unfamiliar territory. And it's going to feel a little uncomfortable, but we're going to get through it because we need to get through it. So what we're doing with our Focused Population Initiative is zeroing in on 12, 24-hour, 36-hour, 48-hour, 60, and 72-hour checkpoints. So taking the bundle concept that our clinicians and our nurses are already familiar with, they're very comfortable in that 3 and 6 hour space, and saying, what do we want to see in 12 hours? What do we want to see in 24 hours, 36 hours? And building in standardized checkpoints to determine, are our patients progressing or are they not? So this is taking the idea of high reliability and building some lanes in place with standardized points in time to create a forcing function for our nurses at the bedside to stop, drop, and assess, and providing them with a roll-up of assessment points, standardized assessment points at 12, 24, 36 hours to say, yeah, we're progressing, or no, we need to course correct. This work grew out not only of our data, our quantitative data, but also of our qualitative review of event reports and mortality where we saw failure to rescue, where from a retrospective scope, we're looking at the progression of a patient or failure to progress of the patient, and I would talk to these charts when I'm reviewing them. I'm cheering the nurse on to say, wait a minute, don't you see that? But we have the advantage of seeing that in a retrospective scope, looking back a dedicated amount of time to review a chart. But a busy nurse at the bedside doesn't necessarily see what's subtly unraveling in front of his or her eyes. So these 12 and 24-hour, 36-hour checkpoints are designed to stop at 12 hours. Not 12 hours on a shift 12-hour, but 12 hours on a patient-centered 12 hours. The 12-hour that I'm talking about starts at time 0. So at 12 hours, my nurse gets a pop-up that says, of these variables, where does the patient stand? And if the patient is not progressing, then here's the report summary that you're going to provide to the provider so the two of you can work collaboratively to correct before this becomes a big problem. So our hypothesis then is on using these care bundles, which essentially our care bundles identify those key care drivers by time frame of patient stay. It's a tool, as I explained, to assist our nurse at the bedside in the conversation with the provider. It provides that interprofessional care approach. It establishes those care timelines, provides the specifics of the care plan, and helps to standardize the expectations of care. But ultimately, our hypothesis is that by using these bundles, we can prevent the things that we have determined are problematic. And these are things that we've determined through analysis of our data, that our patients are experiencing respiratory failure, that our patients are experiencing acute renal failure, that we have opportunity to standardize our post-discharge follow-up. We have built-in prompts to address holistic patient care such as ambulation and nutrition. Are our patients eating? Are they drinking? These are the things, the subtle things that get lost when we're providing care at times. Overall, the bundle work is going to build in our checkpoints and our flags for early recognition of failure to progress towards recovery and then prompt action. And that's key. The prompting standardized action. What do we anticipate? What do we expect? So the bundle work, it's big. We've zeroed in on our key 8 hospitals for both volume and variation. And volume and variation is a term that I have coined to help easily express where our opportunity lies. Because our top 8 hospitals are not necessarily our largest volume hospitals, but our hospitals where we see the biggest variation in our care. So I'm going to let you take volume and variation back to your facilities and use that because it's really a nice way of summing up where we have opportunity. We started off with socializing the concept of the bundle work and presenting the data and the rationale for the bundle work with our leaders and gaining leadership support. Then we identified our clinical leads at each of the focused population hospitals and our performance improvement partners. We then formed the work group that's intent upon designing the care bundles, and we have an IT group that's also meeting on alternating weeks. So as our clinicians on the subject matter group are identifying the components of the care bundles at each of these checkpoints, our IT work group is meeting on alternating groups to operationalize and create the tools for the bundle work. And ultimately then, after the bundles are built, we'll have a process engineer-led implementation in each of the big 8 sites to pilot with tight parameters on monitoring and course correction. There's some key reliability tactics for our bundle work, and that's optimizing the technology that we have in terms of our sepsis predictive score and our risk for readmission score. So that's a new technology we have through our Epic electronic health record. We're going to maximize our tools such as checklists, if-then algorithms, and forcing functions. We're incorporating the people into our workflow design, because just launching technology without incorporating the workflow to maximize the use of technology results in a new piece of technology that nobody is using to its fullest advantage. And then, as I indicated, our performance engineers will monitor, measure, assess, revise, and spread the work. This is not the only area in which we are infusing high reliability tactics, and I've provided you with a crosswalk of our previous focus before this push for reliability, and how you can see with our previous action items the concept of passive education and actions runs through the previous action items, where when we talk about reliability tactics with these particular areas of focus, we're really including more processes, tools, and technology to provide those forcing functions to get our practitioners and our nurses and our employees set up for success and minimize those gaps and lapses in our potential processes. Ultimately, though, the goal behind all of this, and this goes back to all of the deeply personal experiences that we've all had, is to minimize our harm. One of my favorite quotes is, "Statistics are patients with the tears wiped off." Because that's why we're here. We can talk about numbers, we can talk about events, but all of these are individuals. And I've dogmatized a quote from Berwick in hopes to inspire all of you to let's wipe out harm. So let's have more nights in one's own bed, more graduations and anniversaries, more travels and adventures, more storybook endings. And let's keep that resilience in mind, because we can bake a better cake and we can have good outcomes. Thank you.
Thank you, Alan. Next, we're joined by Charlton Park, who will present a model for quantifying the value of quality and patient safety within high reliability organizations. Charlton is the Chief Financial Officer and Chief Analytics Officer of the University of Utah Hospitals and Clinics in Salt Lake City. He oversees the financial planning, budgeting, general accounting, operational and capital financial planning, analytics, and revenue cycle functions. He has played an important role in the development of various integration models across several clinical programs using financial and clinical data to increase collaboration and alignment between physician specialties and the hospital. Charlton has the unique ability to integrate the value of clinical quality initiatives. He has also played a key role in developing the organization's Value-Driven Outcomes initiative, which provides accurate, actionable cost accounting and outcomes information at the visit level. Charlton received a Bachelor of Science degree in Information Systems from the University of Utah and his Master of Business Administration and Master of Health Sector Management degrees at Arizona State University. Please join me in welcoming Charlton.
Get this back on. Thank you very much. I want to thank Kevin. I also want to thank Ellen for her presentation and actually touching on ROI. It is my belief that as we improve quality and reduce variation, it is a positive financial impact that we see consistently. So again, I'm Charlton Park, University of Utah Hospitals and Clinics in Salt Lake City, Utah. Hopefully some of you are familiar with where we are, nestled in the Wasatch Mountains in Salt Lake City, Utah. A little bit about our healthcare system. We're an academic medical center, 4-hospital system up there in Salt Lake County. We've got a growing network of community clinics up and down the Wasatch Front because we are the only major referral center or academic medical center in the Intermountain West. We cover greater than 10% of the continental United States. We are a major referral center for the various affiliates we have, rural and otherwise, through Wyoming, Montana, Idaho, and Nevada. We've been steadily growing over the last decade. As an organization, we've eclipsed, we're approaching $4 billion in total expense budget. Here's a picture of our campus. This is the main campus of the university with the Health Sciences Center up towards the hill. You can see about halfway down the hill where the Academic Medical Center is and the rest of the campus. We're very proud of the quality credentials we've achieved over the last decade. 9 years in Vizient's top 10 in quality in the nation. We're very proud of. We hope to make it an even 10 this year. Also proud of our other quality ratings and different various merit badges we've achieved as a system. So I'm here to talk about my role in, it's kind of interesting to have a CFO here speaking at a quality summit, but I want to talk about our journey at the University of Utah Hospitals and Clinics and how me and my role as Chief Financial Officer has become more and more involved in the quality and value improvement work within our system, and how I've been able to partner with our Chief Medical Quality Officer, Bob Pendleton, in helping to engage our physicians in this work. So several years ago, our senior leadership sat around a table after reviewing publications like this. This one from Professors Kaplan and Porter at Harvard Business School, Why Medical Bills Are a Mystery. In this and other publications at the time, they're talking about how hospitals don't understand what it costs to take care of individual patients. Every hospital knows what it costs their total costs are in aggregate and whether they're making more money than they're spending, those sort of things. But what does it cost to take care of an individual patient that seeks care within their facility? Porter and Kaplan said this is the unrealized issue for most hospitals and might be the key to unlocking value and changing healthcare. The ability to understand the cost of caring for an individual patient and how that relates to the outcomes achieved or the quality. So our senior leadership team said, we're going to figure this out. We're going to resource it, and we're going to understand at a detailed level accurately what it costs to care for each patient within our system, and we're going to develop a data foundation of quality measurements, process measurements, and outcome measurements that will be able to relate to those costs and understand what our patients and what are our insurers and what our employers getting for their investments in our system. So this is how, what happened next was a team of about 30 people from finance, from quality teams, from clinical areas, from the medical group were sequestered off campus to focus on this for the better part of 6 months. And what they came up with was a data foundation that would allow us to create this transparency about value and engage our physicians in this work. Within our system, it starts with our clinical, it's all driven by data, creating this foundation to engage our teams. Starts with our clinical source systems and our financial source systems. During this process, we transitioned from Cerner to Epic. So we had those as our primary clinical source systems, and then PeopleSoft, Lawson, our other financial data sources. All that information flows into our data warehouse, where we created clinical and financial data marts in standardized terms so that we're able to relate clinical data at the visit level with financial data at the visit level. Then from there, we built very detailed cost allocation methodologies within the various units, nursing units, the operating room, the emergency room, ambulatory clinics. for every different type of cost, whether it be labor, supplies, pharmacy, et cetera, we created detailed cost allocation methodologies that allowed us to take that cost based on what happened in that clinical encounter and allocate the cost to the individual visit level. Then on the other side of the paradigm, the teams, we created specific quality and outcome measurements and rules, patient-reported outcomes, quality outcomes, regulatory outcomes, and many, many process measurements were all developed based on every different clinical condition and aligned with the visit level, the patient visit level. And that created a massive data foundation, more than 300 million rows per year of data that was now available for reporting within reports, dashboards, and scorecards to really create transparency around the value at a patient level, which was being created, and identify the variation in care that existed within our system. So to walk you through the costing portion of this is just a quick example of a patient of ours. So this patient experienced an appendectomy. They presented at 10:45 a.m. In our emergency department. In our emergency department, if any of you are familiar with an ED, a lot of resources there were utilized for this one individual patient. Labor, supplies, imaging, pharmaceuticals, labs, and various other services. Each of those services or resources used has a cost to it. From the emergency room, they went to the operating room, where again, more labor, supplies, and other services were provided, all at an individual cost. From there, this was a 83-year-old patient with other comorbidities requiring this patient post-op to be sent to the surgical intensive care unit, higher and more costly level of care and as far as a nursing unit goes, where more labor, supplies, pharmaceuticals, labs, and other services were used, again, each having their own individual cost. From there, the patient was discharged to the step-down and floor units and was released and discharged on day 4. Now, if you can understand the accurate cost of each resource used as that patient flowed through those various units, all the different budgets they touched, then you understand the total cost of caring for that unique patient. And that unique patient is going to be very different from any other patient, including any other patient that might have had an appendectomy. There's going to be unique decisions made by our clinical teams for this patient that led to the use of different resources with their different costs for this unique patient. So our costing system gets at each of those uniquenesses, each of the decisions made by the clinicians and the surgeons to give us a unique cost for this one patient. Now, we've been able to do this for all of our system, inpatient, outpatient, or otherwise, creating that database of cost data that allows us to identify variation and what's driving that variation. So this is a view of one of our early analytics that allows us to understand the average cost by provider. So within this analytic, you can select a MSDRG, primary diagnosis group, or a primary procedure, and then what shows up is a comparison for the average cost per discharge of the providers who have performed that procedure or MSDRG. So in this view, we've just got it filtered on total knee replacement, and you can see the variation that exists between each of the surgeons that are performing this procedure. Then, because there's a massive amount of data, we're able to drill into each of those cost categories and really understand what's driving the variation. You can drill into what we call facility utilization, which is largely labor, and see the allocation of labor for these patients. This is where you'll see if a surgeon spends more time in the OR, there'll be a greater allocation of the nursing and tech and other labor that exists in the OR. You can drill into the imaging and see the different types and variation that exists in the types of imaging that is being ordered by these physicians for their specific patients. You can drill into lab and see the different utilization of lab testing for these, again, joint replacement patients. The same with pharmacy and on and on. And each of these cost categories has 4 levels of drill to get you down to the specific imaging study or pharmaceutical that was used with its individual unit price. And then finally here with the joint replacement, you can drill into the supplies. And as we all know, with major joint replacement, supplies are a big expense. And within this tool, with our 6 surgeons, you can drill down into the implant supply, which is one of the causes of variation, and identify the actual preferred vendor of each of these surgeons. And within our system, all 4 of the major vendors are represented here, which is something we've been working on to standardize and reduce costs as well. So other analytics on top of that we've created, we've called this one our Value Explorer. This is available for all of our physicians. You can, just on the left side there, select the performing provider, and then instantly pops up a comparison of that provider with their colleagues in their department. So in the middle region there, you can, once you've selected a performing provider, you can look at all the DRGs that their patients have been assigned and compare them and their average cost per discharge with their colleagues, and identify, an individual provider can then identify where they're out of line with their colleagues, and then click on that DRG and identify, is it pharmaceuticals, is it supplies, is it a length of stay or labor issue that is driving their variation, cost variation with their colleagues. And then drill through and get the specific costs. So if it's pharmacy, you can understand what drugs a provider is using compared to their colleagues, and really get out some of that low-hanging fruit as far as making some changes where it was just an awareness of the cost that is all that's needed. So that's kind of what we've done with our costing model. At University of Utah Health, it's almost a requirement that we cannot have a presentation without bringing up our value equation. It's so important, and it's part of the DNA of our organization. And it's really what's necessary to engage our providers in this work. I have not had a lot of success in my organization sitting down with the orthopedic surgeons and talking about hospital cost and why they should reduce hospital cost. But what I have had success with is sitting down with them and talking about the value equation and the quality measurements, patient satisfaction, and coupled with hospital costs, and why we need to continually work towards improving value for our patients, for our insurers, our payer partners, as well as our employer partners. And that's what's been the key to engaging our providers in this work. So we've sat down with our orthopedic surgeons and shown them this data and worked with them to provide accurate process improvement data, accurate quality and outcomes information, and we've engaged the providers in actually designing the analytics. What will work with there? What distribution method do they want to see it in? Do they want to have it come to them via email, or do they want to log into the system? Do they want certain aspects of it integrated with our EMR so that they don't have to go into other systems? And we've been able to do all of the above for our providers. And we've been able to surround them with the support teams that they need in order to understand and engage in this value improvement work. So one of the big changes we made a few years ago to engage our providers in this is our Chief Medical Officer, Tom Miller, got rid of the majority of our medical directors. It was kind of an archaic way we were doing things within our system, and appointed a number of what we call chief value officers. So within our clinical departments, we named clinical departments and divisions. We named chief value officers for the inpatient and for the outpatient for each division and specialty. And the role of those chief value officers is to really be that liaison with the hospital in engaging their division in the value improvement work. And then with each of those chief value officers and the various clinical conditions we focused on, we assigned subject matter experts and support teams to really engage those value officers and their divisions and the physicians in this work. So you can see we've assigned members of our value engineering team, our process engineering team, our quality team, and our decision support or analytics team to be the named resources for each one of these physicians to work with. Their time is so critical and valuable and hard to come up with, that having this named support team that they can call on and get resource and work done while they're when they're available, and having that those resources available to support them has been critical to moving this work forward. So here's an example of what we call perfect care. With our providers in each clinical condition, we identify different process measurements, outcomes, or quality measurements that are important to that physician group. Some of them may be regulatory or otherwise dictated by the physician. And we've made those in large part binary for this purpose, so that we can create what we call the perfect care metric. So you either had a readmission or you didn't. You either had a hospital-acquired condition or you didn't. You either had a skip fallout or you didn't. And within a scorecard like this, if you got the positive outcome on each one of those measurements, we call it a perfect care case. Otherwise, it was not. And then you can see in this view, and there's many like it, in the blue line, we measure the proportion of perfect care cases. And in this view, we're looking at C-section. So the number of perfect care cases is steadily growing over the months, where all of those measurements had the positive outcome. And then you can see the average cost per discharge with this patient population. As we can consistently see, as we standardize care and get all the physicians working together to standardize their processes and be paying attention to the same things, we actually see a reduction in cost over time. And there's a number of clinical conditions where we've seen this same thing happen. Here's an example of our joint scorecard, and this is the fourth year edition of this. They've changed their metrics a number of times for perfect care, but they still look at patient safety indicators. They want to make sure they're discharging their patients to home rather than skilled nursing, make sure the patients don't return to the ED and there's no hacks or PSIs. But you can see in this view, the blue line or the perfect care percentage is up over 90%. The cost continues to go down. And in this view, that black line on the top was the cost we were at 3 years ago, as they've been able to drive the cost down from where it was 3 years ago in black to where it is now in the red line. And it's just this continual process improvement that has really engaged this team. This scorecard gets sent out monthly. The surgeons and the care team all respond to it, congratulating themselves or asking questions about what is different in the new data. So really having that accurate, timely data has helped engage this team in that important work. And then there's other information that the physicians are interested, anesthesia technique, and individual cost trend, the supplies, pharmaceutical cost, implant cost that the providers also want detail on. We've also got a sepsis scorecard, and similar to the things Ellen was talking about. We talk about what's going on up front as the patient enters the system, but we're also monitoring the MUSE score, the Modified Early Warning Score, throughout the patient stay, and really keeping an eye on specific things that the providers and care teams are looking at throughout the patient stay in order to reduce that variability and keep the focus on what's most important for caring for these teams. And as a result, when we're doing that, we consistently see a reduced cost for those patients where we're keeping an eye and monitoring all those things. One of the challenges we've had as a team is really going along with engaging all of our faculty in this, over 1,600 physicians, is educating them on the successes and what's going on within the system. And one of the avenues we've used to further engage the physician is our Accelerate, our intranet website, where we've been able to highlight different stories and different physicians that are getting involved and are having great positive results in improving value and reducing hospital costs. So there's many examples out there now, around, here's 3 with lab utilization, great reduction there by Dr. Klarkowski. Dr. Pelt is really, again, with joint replacement, is in his 4th iteration of care redesign there with that method of continual process improvement. And then we've had some great success in reducing our drug costs within our organization. On top of that, there's numerous other ways we're engaging our patients to improve the value we provide to our patients and payers and others. We are collecting and using patient-reported outcomes in all of our specialties now. Within each of our specialties, you come to the ambulatory setting, we're handing out iPads or a pre-visit email and collecting physical function, behavioral health assessments for each of our patients that then we're able to relate to the outcomes, to the cost outcomes, as well as our other internal outcomes for each of the patients. We're able to see in orthopedics the type of response we're getting as reported by the patient, whether it be physical therapy or an injection or an actual surgery. And we can see from our patient's perspective what tends to get the best results rather than relying purely on what we internally as a hospital think is important, trying to rely more on what our patients think is important. We're also providing specific reporting within the operating room. This is our ORCA project, or Operating Room Cost Accountability. And each of our surgeons is bursted monthly this report in their inbox that shows their top procedures. They're able to then click on that and see within those top procedures how they compare their time spent in the OR, their cost per case, and their infection rates compared to their colleagues. And we're also, because we have a health plan and several at-risk populations, we're very focused on the longitudinal care for our patients, the cost over time as well as the outcomes over time. And with this report, we're able to look at specifically at our heart failure patients. And on the left, you can click on the top patients there, and then the graph produces a 2-year view of all the encounters that they've had with the system. And then you can go down visit by visit and see all the different touches our physicians and our system has had with the patient, how many times they've been through the ED, how many times they've been admitted, readmitted, and we can better understand, look into why the patients are coming back to the ED. How can we intervene? How can we better, across the board, care for these patients and keep them healthy and keep them from bouncing back into the hospital? And then with these as well, we can drill in to see specifics at the visit level as well as the cost associated with each one of those encounters. And very quickly, we were also using predictive analytics to better set up our care teams to care for our patients. This is just a view of predicting readmissions. So within our system, we're evaluating all our patients while they're still in-house to understand what is their probability of being readmitted. And our nursing teams and our care teams are able to see these updated real time and understand as they're discharging patients, which patients have the most likelihood of being readmitted, and they're able to be more focused on time and attention to those patients and making sure those patients who are at moderate or high risk of readmitting, make sure they're taken care of, and then again follow up with them post-discharge to make sure they're taking medication and following through with their care plan. Another example is our no-shows predictive analytics. So we're able to look through and evaluate which patients we think may not show up in clinic. We're able to proactively reach out to those patients and either reschedule or even in some cases double book those patients so the provider's time is secure and we're making the best use of that resource. This has also been integrated within Epic so our providers can see within their schedules what those no-show risks are as well. So in summary, again, we're very focused on value improvement, bringing that detailed cost analytics together with outcomes, quality, patient-reported outcomes, and process measurements has really allowed us to engage our providers in this value improvement work. It's really not about hospital costs, but about creating more value. Again, in Utah, we've got an interesting environment and market where we're being squeezed on all sides, and we need to be able to reduce costs because our payers are demanding it of us, and it's what we want to do to reduce costs for our patients, for employers, and our payer partners, while improving our quality and our patient experience all at the same time. And that will continue to be our focus. So thank you very much.
Thank you, Charlton. We now invite the audience to continue to share your questions. The room moderators will continue to circulate the room and collect your question cards. We've already got a few here that we can try to address. And I'll try to prime the pump here. First question is for Ellen. Ellen, which high reliability organization principle is the most difficult for hospitals to implement?
I really like that question. It gives me an opportunity to expound even further on high reliability. But essentially, I would say it's reluctance to simplify. And this is a two-part. Not only is it the most difficult, but it's also probably the most important. From both the idea of a reluctance to simplify at the point of care. So using the cake example, the reluctance to simplify would have negated the workaround. When we simplify things, we create the workarounds that lead us to the lapses and gaps. We also create a situation in which we may be solving for the wrong problem. And that's not only inefficiencies that we've then baked in, but it's also wasted time in solving the wrong problem. Yet it's human nature to want to simplify. We want the easiest answer to be the right answer when we're busy and we have competing priorities. So that lapsing towards, deviating towards the norm of simplification is probably our biggest threat to reliability.
Thank you, Ellen. The next one's for Charlton. In the cost per case by provider, how do you integrate the severity of illness, risk of mortality?
So that's been a challenge throughout because, and there was another question that got at this. You put up a chart like I did and you see the variation in cost. When years ago when I first sat down with the orthopedic surgeons and made that mistake, you immediately get the response that my patients are sicker or my outcomes are better. And that's almost never the truth. Really, the variation is caused by different things. So we've instituted several different risk adjustment methodologies, but none of them are perfect. The better success we've had is just working with our Chief Medical Quality Officer, Bob Pendleton, and helping our providers get over that bump in the road and that speed bump. Forget about risk adjustment. When you've each got 50 cases and we're comparing 50 to 50, and it's the same procedure, we're talking about variation. We're talking about standardizing care. We're talking about moving in the right direction. We're not talking about who's a better surgeon and whose patients are sicker. Everybody has room to improve along that value journey. And that's been the need of our video data, is none of it is punitive. We do want it to be transparent and available, so it's actionable, but nobody's getting, it's not part of your annual evaluation, and if you're the most expensive provider, you're gonna get penalized or anything like this. It's all about process improvement.
Thanks, Charlton. Next one's for Ellen. When processes have been developed and education has taken place, how do you deal with accountability of management and staff when protocols are not followed consistently?
So this is where we can't monitor what we don't measure. And this is where our performance improvement engineers really play a part in the sustainability and the spread of any improvements that we've put into place. We should not engage in a performance improvement initiative without determining how do we know if it worked. And part of that then leads us to the accountability piece, which also includes a degree of validation. So one of the things that we do in healthcare that we could do better is we implement and then we assume. Anybody who's ever put a nurse-driven Foley catheter removal protocol in place knows what I'm talking about. We have a great protocol, and then we've put it into the EHR, and we've worked it into the workflows. But go out and find out if you're actually using it. And this is some of what I call pulling back the covers and looking in the medicine cabinets. A great example of this is we did away with bath basins, supposedly. We were not using bath basins anymore. I did a walk around a unit in one of our hospitals and immediately found bath basins with soap stuck to the bottom of them, indicating they had indeed been used. So validation of the principles that we put in place is so important. It's the concept of trusting and verifying, but then measuring and creating that 360 feedback with data-driven observations to hold people accountable.
Thank you. Charlton, what was your analytics platform homegrown? And if so, how many FTEs are involved with building and running the platform?
Good question. So at the University of Utah, we had some very visionary leaders decades ago, and we created a data warehouse in the late 1990s. We actually have, and that's the platform we're still on today, and we've switched EMRs, I think, 5 times since then. But it's all mapped into the data warehouse and a single terminology, so we can open up Tableau or business objects, and I can query visits back into the late 90s. So our system's really agnostic. So we built our costing model. All the quality analytics are housed within our data warehouse, which makes it very flexible. And then we're able to layer on our analytics tools, Tableau, business objects, or just query the data and pull it and manipulate it in Excel. But it's taken a robust data warehousing team. It's about 35 members, and our analytics or decision support team has about 15 members as well. So some steady investments over the years in those teams have helped that to flourish. But we like to have it all within that data warehouse and not become dependent on a third party in order to support those systems.
Thank you. Ellen, what tactics do you use to encourage employees to report near misses? Employees often think that if they report these, their job within the organization will be in jeopardy despite being reassured otherwise.
So let me first state that we have not mastered this art yet, but there are specific tactics we can put into play, especially as leaders, to address that fear of reporting. And I think it's two-part. The easy explanation that people throw out is the fear of a punishment or consequences for reporting. But the other part, I think, is more subtle, and that's the idea of learned helplessness. So we also hear when we dig deeper that people don't report because they don't think anything is going to be done. And here's where we as leaders have such an opportunity to push forward with one important concept around the retribution, which has to do with our culture, our just culture, and ensuring that people are aware of the processes that we put in place to determine, is there an intentional deviation versus a human variation which is acceptable. So spelling out the just culture principles, living them, verbalizing them, and demonstrating that they're put into play whenever there's an event that occurs. So that's part of the structure. But then as people, as leaders, we have the obligation to continually present our culture of safety and using such key tactics as our leadership rounding. So being out and about and thanking people for reporting, asking critical questions of both our clinicians as well as our ancillary staff of how are things going today? Is there any problem that's happening on your unit, within your processes, that we need to fix? Are you seeing anything that puts us at risk for harm? Asking those questions, listening to the answers, and then responding to them. So as leaders, the commitment to be out and about and rounding and talking to our people and understanding, and then thanking them for reporting, and then demonstrating through lessons learned and safety stories how the information that we get and obtain is put into play, and we've created action attached to it, and sharing the good stories that happen too of harm prevention. So there's no easy answer to it, and it really has to do with your culture of safety and your just culture, and then your leadership behaviors that reinforce that we're not just talking the talk, but we're walking the walk as well.
Charlton, what variables are you using to determine risk of readmission?
Oh, I knew that'd be a question. So I would be happy to share our model. It originally started with 20 different variables. It's narrowed down to, I think, 6. But whoever wants to know, happy to share it. Homegrown model as well. But I think there's about 6 different variables. Which ones they are that remain, I'm not sure.
I've got one for Ellen. So why was there a hole in the cake mold? I'm not a baker, so I don't know.
There's a hole in the cake mold because of this. And first I have to tell you, my mother baked a lamb cake for Easter every year for my entire length of time. And it was always a big deal, the Easter lamb cake. And well, this year my mother's no longer capable of baking the Easter lamb cake, and the torch was passed to me, and I am not a baker. So I found myself an Easter lamb cake, and I thought, my mom can do this, I can do this, right? I have a PhD, how hard can it be? Well, there is a hole in the lamb cake because the lamb cake comes in 2 parts, the back and the front. And what you are supposed to do is put the pieces together and fill up the cake batter through the hole and bake the cake as one. Well, me, the baker, I thought, well, there's a hole there. That doesn't make sense. I put the wax paper on it. I filled up both sides, baked them separately, and then tried to make them come together. That did not work. What you didn't see were things like pencils and skewers and peanut butter trying to hold the cake together, as well as me yelling at the 14-year-old and 10-year-old at 11:30 at night, the night before Easter, get me a skewer! There were numerous other factors, such as the wrong cake. You need to make a dense cake, and it was too warm to try and do it. I got up at 5:30 in the morning, Easter morning, bound and determined, because I went on Pinterest and saw all these successful cakes made by Baker Mommy and these things, and I said, I'm going to make that cake. And I went to Martin's and I got the equipment and I made the darn cake. I was so proud of it. I wouldn't let anybody eat it.
I'll remember that the next time I make a lamb cake. Thank you. Ellen, can you address how claiming to be a, quote, high reliability organization, unquote, is perceived by the public, and specifically the media, if an adverse event actually occurs.
Absolutely, and that is difficult. And if you recall just a couple questions ago, I started with the disclaimer that this is a work in progress. And so we, by no means, have crested the hill on high reliability, and we never will. It's a moving target. However, I would throw out to anybody who would challenge, what's the alternative? If we stop striving for high reliability, then are we accepting that harm happens?
Charlton, one last question. How do you foster the culture of data transparency with your clinicians?
Oh, that is challenging, but it's been something that we've had a good start at. My predecessor, CFO, has been just completely open books as far as anything you want to know about hospital costs from the day I joined the team 11 years ago. So we have very open books financially as a hospital organization. The challenge we've had is as we've gotten more sensitive data, obviously our cost data is data you wouldn't want necessarily our payers to see. They may misinterpret it. And one of our focus within the analytics that I've shown is, and one of the challenges we've experienced in the past is, you don't layer in the CEO's salary or all these indirect costs into a scorecard that you then show the orthopedic surgeons. It's not helpful. We've concentrated on just the direct physician controllable costs to use within our analytics, things that they can do something about. And that makes that data really quite sensitive because it doesn't include fully loaded cost, all of our costs. So we need to make sure we don't make that too transparent. We do have clinicians. We have essentially a closed medical staff. They're part of the University of Utah. It's our faculty, a different organization. You got the School of Medicine and the hospitals and clinics. And some of those clinicians do float and have privileges outside of our system. So there's a confidentiality training that each physician takes before they can access that cost data that lets them know about some of the challenges around the data as far as sharing it externally. But internally, anyone who wants to see it, who goes through the confidentiality training has access to it. And that means they have access to their colleagues as well. That was one of the challenges we had to get over was whether I get to see my colleagues' work. Well, it becomes challenging if you can only see yourself and have nothing to compare it to. But for that purpose, we haven't had any problems with that. Again, the data is not meant to be punitive in any way. It's meant to create actionable transparency to data so that our clinicians can make better decisions and the hospital and the system can support them in doing that.
Thank you. Thanks once again to Ellen and Charlton. We're not going to break until 11. Please visit the poster presenters just outside the door, and please return as we'll resume promptly at 11.